good afternoon to all listening to us today. My name is Tarik Yasharievich, and I work in the media team of the World Health Organization here in WHO headquarters in Geneva. I welcome you to this side event to Brussels VIII conference entitled My Health, My Right, Who is Left Behind in Syria? This side event is co-organized by the World Health Organization, the Republic of Austria, and United Nations Population Fund. You have already received the invitation, and thank you very much for registering. We had more than 200 people who registered. Hopefully, all of them are with us. I will, despite that you have received the invitation, I will introduce our panelists in a minute, but let's just remind ourselves why we are here today. And many of you were with us last year when we were trying to highlight the health situation in Syria. And as we have said in the title of this side event, who is left behind? What has changed since last year, and what needs to be done? As you know, it's been 13 years since the beginning of the conflict, and there are more people in need of humanitarian assistance in Syria now than any time since the war began. And there's all this new generation of children who are growing up in Syria, only know the war, and who have never lived in a peace, who lived through trauma, displacement, and now living in poverty. Conditions have only worsened in recent times. Currently, an estimated 16.7 million people need humanitarian aid. Among them, over 15 million, 65% of population, require health assistance. Now, this crisis in Syria is also affect health of the population, with an estimated 90% of people living in poverty. We have seen a threefold increase in prevalence of malnutrition in the past 5 years. An 80% increase in depression since 2022. And today, 50 to 80% of all cancer patients are unable to complete treatment due to shortages of medicine and disruption of health services. At the same time, the country has faced numerous disease outbreaks, such as cholera, measles, hepatitis A, along with the resurgence of endemic diseases like scabies. But as the numbers of Syrians requiring aid has surged, resources have declined to historic low. Funding for the country declined by 27% in period 22-23 and is expected to be further reduced by 30% or even more this year. And this would push humanitarian agencies to make difficult choices and prioritize between equally needed services. And let's not forget the earthquake that took place in February last year, and that only worsened the funding gap and added another layer of hardship for people who have been already impacted by years of. Now, this side event that we are organizing today is coming ahead of the 8th Brussels conference on supporting the future of Syria and the region. As I said, co-hosted by the Republic of Austria, WHO, and UNFPA. This side event intends to highlight the human cost of declining funds and what remains at risk if we fail to urgently provide the people of Syria with the resources they so urgently need. With a region affected by several different crises, it is important to understand the scale of the needs in Syria and not to forget its people. So we will really try to have a dialogue today, and we will hear from a number of panelists that have been presented to you in the invitation that we will reintroduce. But let's start with the ambassador to Austria, ambassador of Austria in Damascus, His Excellency, Mr. Peter Kreuz, who can give us some opening remarks. And I remember, Your Excellency, we have been here last year, and you have been talking to us. So the floor is yours for your opening remarks, and then we will go deeper into discussion on what is the situation and what are the needs. Your Excellency, the floor is yours.
Thank you very much. First of all, thank you for the invitation to co-host with the World Health Organization, as I am very frequently in Damascus and I also travel in Syria. I know of the importance of your work. I know that the situation has not stopped becoming actually more difficult over the past years. We see it also in the numbers of people who need aid. What I would like to highlight especially is the stark difference when you come with the motto, with the very nice motto that nobody should be left behind. What I see is that in Syria we have a two-class medicine. There are still private facilities that can offer very high-level services, but they are actually unavailable to the vast majority of citizens in the country because they are simply very, very expensive. And they are very, very expensive because the items needed to provide this type of medical support need to come in under very difficult situations. And I speak here also about the unfortunate still existing problem, although it has been known for more than 10 years, of overcompliance with the restrictive measures that makes the items needed very often very expensive, very difficult to get by. Probably we will hear more also from your side, which means that actually these medical services become much more expensive than they would need to be. And also what I see is that the public health system on the other side that is underfinanced, that does not have this access, that does not have these means, cannot offer the required level of medical support to the situation. And this is what I see in Damascus, what I also see when we travel to different parts of the country. And I think last year was a special moment. It was the 30th anniversary of the only second so far World Conference on Human Rights, 1993. And this conference produced a declaration and a program of action that was supported by all UN member states at the time. And there it was clearly spelled out by all participants that we cannot differentiate among human rights. They all have the same importance, they all have the same level. And among these rights is also the right to health and the right to an education. So it's what are the issues, what are the problems, and here I also count on the other panelists to go more into detail. Thank you very much for inviting me.
Thank you very much, Your Excellency, Kreuz, for these opening remarks. We will come back to you shortly. Just to remind everyone, something that I should have said at the beginning is that we have a simultaneous translation into Arabic. So those who would like to listen into Arabic, please go to the interpretation icon at the bottom of your screen and choose the language that you would like to listen in. Also, we would like to hear from all of you following our discussion and to have 15 minutes of a debate at the end. So all those listening to us, please use the chat box to put your comment, to put a question to any of those who will be speaking. And who will be speaking today? So with us, we have Dr. Iman Shankiti, who is a WHO representative in Syria. She's based in Damascus. We have Dr. Hani Al-Taleb, who is the founder and CEO of Relief Experts Association. We have also Ms. Bashira Tabaj, who is distinguished midwife and who will tell us about her experiences a little bit later. With us also is Ms. Rosa Crestani, head of WHO field presence in Gaziantep. Muriel Mafiko is also with us, and she is a UNFPA representative in Syria, based in Damascus. And we have a UNFPA head of office in Gaziantep, Ziad Nabulsi. We will hear from all of them, but maybe just to come first back to you, Your Excellency. It's really interesting point you made about availability of health services, but also the high cost that many people cannot afford. So, in your travels through Syria, what are really the implications for the overall population, for those who cannot afford those services that exist? Your Excellency, can you just unmute yourself, please?
The implications are very far-reaching because if the funds are not there and the public facilities that would offer treatment for free do not have the equipment necessary, or it's not functional because spare parts were missing and could not be provided. And we saw this also, and we heard about cases, you mentioned the earthquake, that seriously injured persons simply did not survive because they were brought to a medical facility where part of the equipment was not functional and could be made to provide the health care necessary. So this can have really fatal consequences, and in other cases, patients need to wait and their situation will not improve without the treatment necessary. I mean, this is what I see, this is what I hear about.
Thank you very much, Your Excellency, and this really sets the scene for the discussion to come. And I would encourage our panelists to really jump in and just raise their hand whenever you want to add or to comment to what has been said. So maybe let's start with Dr. Iman Shankiti, who has been WHO representative in Syria for last 2 years. So maybe you can tell us, Dr. Shankiti, what changes have you seen during these 2 years that you have been in this position when it comes to availability of health services in Syria?
Thank you, Tarek, and good afternoon, Your Excellency. Thank you for joining us, and good afternoon to everyone online. Tarek, maybe I would like to go back since when I arrived to Syria 2 years ago. The first time I exchanged $100, I used the exchange rate of 3,700 per dollar. Today, it is 14,000. So you can see it is 2 years later where the devaluation and the inflation has skyrocketed in the country. It's important also to note that if we look at the salaries of staff, healthcare workers specifically, they range between $15 and $30. In the past, when I arrived, this used to contribute meaningfully to the welfare of the family. Right now, it's not enough to pay for the fuel of the cars for them to go to the nearest hospital or for them to go to work. So we are seeing, I mean, the result of socioeconomic decay, the near collapse of the the basic services, and we're also seeing a surge in conflict, whether it is internal conflict or the impact of the regional conflict on Syria. So this has a direct and indirect effect on the well-being of the households and communities, who in return are not able to access services meaningfully. So if we talk about availability of services in the country, we're talking about 63% of hospitals and only 52% of primary healthcare centers are fully operational, while the humanitarian actors on ground are trying to fill this gap, I mean, diligently, but it is very difficult with the current funding spectrum. If we look at the health sector also from a Syria perspective, we're saying that more than 25 health partners out of 62 will be suspending their operations. This translates into around 135 medical mobile teams. This translates into 3 million people who do not have access to services. So this is really a huge amount of people or catchment population who are most vulnerable, who are living in the most vulnerable localities that do not have access to direct services. So if you have, I mean, people like the 6-year-old Ibrahim, he's living in rural Homs. Last month he died. He died because he died of kidney failure because he couldn't access the hospital because the parents could not pay for the transportation to the hospital. So this is a death that could have been averted if services are closer to the community and are more available. In Northwest, if we talk about the facilities, it was reported that more than 86 facilities have fully or partially suspended their operations between October 23 and May 24, and this is due to funding shortages. And there's more, around 80 facilities that are at risk and could close very soon, due also to funding shortages. In the northeast of Syria, we only have 1 out of 16 hospitals that are operational. And this hospital is serving around 500,000, 450,000, 440,000 people in camps and camps-like setting. And of course, I mean, many of you know that we had to suspend our referral services from Al-Hol camp beginning of March because of funding shortages. Despite the fact that this service might be resumed soon with the support from some partners. So let me tell you about Osama. Osama is an 8-year-old Iraqi refugee. He lived in Al-Hol camp. He was receiving treatment for lymphoma in Al-Hikma, and he was doing well. His 3rd dose was supposed to happen in April in Al-Hikma hospital. He couldn't get access to Al-Hikma hospital because we suspended the service, and the disease took its toll. He succumbed to the disease. This is a death that could have been averted. This is a death that should not have happened. And of course, we're not talking only about access to services. We're talking about access to medications and access to health kits. We in WHO used to deliver and distribute a lot of medications, and we had seen an 84% decrease in medications that are being distributed compared to last year. That is translating to around 1.8 million people do not have access to basic medications, which could be life-saving and they are life-sustaining treatments. In terms of public health security, and we have been at our lowest, we are really concerned about the situation, specifically because many partners are closing down in their operations. Specifically in high-risk areas or the most vulnerable areas. So this is depleting critical contingency stocks on the ground, and it's depleting their ability to detect and to respond to different emergencies and public health threats. And we all know that public health threats and disease outbreaks do not know border. So the last cholera outbreak, it started in Syria, but it continued towards Lebanon because people move, and it is not restricted to one area. So when you have a problem, and it's important to note, when you have a problem in other sectors, the health sector is the safety net. So it always ends up in the health sector or the health system who needs to react to the shortages or the shortcomings of other sectors. And if their needs are not addressed, then these people fall between the cracks. So at the patient level, a question to all of us is important to note. Do we serve? I mean, there has been a lot of calls for prioritization. We need to prioritize. We need to be more efficient. But the question is, what do we prioritize? How can you do more with less? Do you focus on a 6-month-old child who is malnourished, or do you focus on a patient, a 40-year-old patient that has kidney failure and needs kidney dialysis? Or do you focus on a mother that is in obstructed labor? In terms of health security, do you focus on supporting surveillance, or do you focus on laboratory diagnostic or vaccination? So these are decisions, these are questions that none of us are ready, or choices none of us are ready to take, because all of them are equally important. So last but not least, failure to act will cost us really dearly. It will, first of all, result in migration, increased migration, which we are already seeing. It will result in increase in illicit drug trafficking, and it will result in increase in terrorism within the country, and will have its impact and toll within the country and outside the country. Additionally, it will have its own negative coping strategies or mechanisms that will be adopted by families, whether it is early marriages or delayed care seeking. So last but not least, we need to ensure that everyone has access to services and wherever they are. And of course, health should be treated as a human right. Over to you, Tarek, and I hope I didn't take more than allocated time for me.
No, it's perfectly fine, Dr. Shankiti, and it's very important to hear these numbers, and it's a very bleak picture that you have painted here for us. Indeed, health system should be that safety net, and if we don't have a health system that can provide basic health services, then consequences will be horrible for everyone, and way beyond health, but on an overall social and political situation. But let's focus on those who are the most vulnerable, and I would like to ask here and turn to Muriel Mafiko, UNFPA representative in Damascus, who is advocating for well-being of women and girls. So everything that we have heard on the situation, socio-economic situation, but also situation of a health system, and also lack of funding, what does it mean concretely for women and girls in Syria?
Thank you very much, Tariq, and let me also recognize His Excellency and thank him for co-hosting this event. I think we heard earlier from Tariq when he gave us the numbers of people who are affected by the humanitarian crisis. It is a number that is staggering by any standard. 16.7 million who are in need of humanitarian assistance. Out of that number, I think it's important to recognize that almost half of that number are women and girls who are affected. And what is also important to note is that about 4 million of those people are women and girls of reproductive health. Now, these are women who have unique needs, they have unique health and protection needs. So that is the context. And behind those statistics, it's also important to recall that we are actually talking about real people living real lives in real time. So the statistics are staggering. The statistics are shocking, especially when you see that we are actually having the highest numbers since the beginning of the Syria crisis. We also know from many humanitarian situations across the world that when crisis strikes, it is women and girls who pay the biggest price. It is women and girls who pay a disproportionate burden. They bear a disproportionate burden of humanitarian situations. So the same applies here in Syria. So in terms of what we see as major challenges affecting women and girls, I think the first issue to note is that women and girls are amongst the most vulnerable, the most impacted by the crisis. So how do they experience this crisis? And I'll reflect here on what I have seen as well. And this was also confirmed by His Excellency when he shared with us what he sees when he travels across the country. So what we see are the unique vulnerabilities that are faced and experienced by women who are displaced. I went to Al-Hol camp a few months ago. I met and talked with displaced women who are in Al-Hol camp. Their situation in terms of their health needs, their protection needs are dire. So women who are internally displaced, girls who are internally displaced, face unique vulnerabilities. We also know from recent studies, and this figure was mentioned already, that over 90% of the population is living below poverty. So what does that mean? It means they are unable to meet their basic nutrition needs. They are unable to access basic health services. And this is what we see across the different governorates. We see people who are unable to access basic health facilities, including reproductive health and gender-based services, gender-based violence services. I want to share the experience that I had recently also in Aleppo, in a village, Tiara, I think it's called, a village in rural Aleppo, where we saw just how scant the services are when it comes to health. We saw the vital role that integrated mobile teams are playing in bringing these vital services, without which really would be having increase in morbidity, increase in mortality. So there are solutions, and that's the point I want to emphasize. That yes, the situation is dire, and yes, there are issues that communities are experiencing, but we also know that there are solutions that we can deploy in order to bring services, especially to the most hard to reach communities that are isolated from service providers. And this is where I think the conversation should focus on what is within our control. And we at UNFPA, working with many other partners, including WHO, we are actually bringing services to some of these hard to reach areas. We are bringing reproductive health services, gender-based violence prevention services, as well as psychosocial support services. We see women and girls coming for these services to rural areas that would otherwise be underserved. So the message, if there's any message we should take, is that collectively, we know what needs to be done. We know some of the innovative solutions that are needed, which can help us not only to bring immediate services, humanitarian services that are needed, but also progressively address issues around resilience. Because without investing in services that will help us to build the resilience at community level, we are going to continue addressing emergencies, continue addressing short-term needs. I want to turn to the issue of the cost of inaction, and I think Dr. Iman touched on this. The cost of inaction when it comes to women and girls is huge, because we are talking of impacts which will be generational. Imagine a mother who falls pregnant and does not have adequate nutrition, a mother who doesn't access antenatal care, a mother who doesn't access proper health services during delivery time. The impact will be lifelong for the mother as well as the baby. So what we are talking about is the need for us to invest in these services, knowing that the benefits are not only immediate, but they will have long-term returns in future. Let me end here and allow my colleagues to also come in, and we can hear from the midwife, who are some of the frontline people delivering services in some of these hard-to-reach areas.
Thank you very much, Ms. Mafiko. This is a great reminder what actually means to invest in health services, and what does it mean to invest in a resilience at community level that you mentioned. It actually has a concrete positive impact on people, especially on vulnerable population, women and girls. So as you said, let's turn to really to those who work at a community level. We are really honored to have with us a midwife, Bushra Tabanj, who kindly agreed to join this discussion. Bushra will speak in Arabic, so for those who would like to continue to listen with the translation, go to interpretation icon at the mid-bottom section of your screen. Bushra, please tell us a little bit your experience. You have been a midwife for over 36 years. What is the situation now? What are the biggest challenges that you face in your daily work?
مساء الخير، شكرا على الدعوة لحضور الاجتماع. اسمي بشيرة طبناش، قابلة من الغوطة الشرقية، خريجة جامعة دمشق 1988 قسم التوليد. بدأت العمل منذ تخرجي من خلال العمل في منزلي لاستقبال الحالات السيدات ومتابعة الحمل حتى الولادة، والدعم في مجال الولادة الطبيعية وتأمين كافة المستلزمات والاحتياجات اللازمة للأم والوليد. التحدي الأكبر كان تقديم الدعم خلال الولادة السريعة والمفاجئة، والتي قد تتكرر حدوثها بسبب وصول الحامل للخدمة بسبب الجهل وبعض العادات والتقاليد في ذلك الوقت. وكذلك الوضع بالنسبة لمتابعة الأمراض النسائية والاختلاطات التي واجهت تحديات تتعلق بنقص الوعي والمعرفة وبعض العادات المجتمعية. خلال فترة الأزمة تغيرت الظروف نحو الأسوأ، ولا سيما محدودية الحركة في بعض المناطق ونقص الموارد وعدم توفر الأدوية والمستلزمات وضياع الممتلكات والأدوات وغلاء الأسعار، مما اضطرني إلى تقديم المساعدة للحالات كانت تستدعي رعاية متخصصة ولكن غير متوفرة، وتقديم الخدمات ضمن شروط بدئية لعدم توفر مصادر الطاقة عدد شموع. وكذلك الحال بالنسبة لعدم توفر الأدوات، مثال التعقيم اليدوي وربط السرة بخيوط حياكة بعد تعقيمها بالمطهرات والكحول لعدم توفر ملقط سرة معقم. لاحقاً، وعند توفر الدعم من قبل صندوق الأمم المتحدة للسكان وتأمين الخدمات عبر مراكز وعيادات الصحة الإنجابية التابعة لجمعية التميز في منطقة الغوطة الشرقية في سقبة، كان من السهل بمكان تقديم الخدمات ضمن الحد الأدنى للمعايير الصحية العالمية ومعايير السلامة والأمان لكل من مقدمي الخدمات والمستفيدات، ولا سيما وجود الاختصاصيين والأدوية والمستلزمات اللازمة والإحالة لخدمات المتقدمة المنقذة للحياة، حيث تمت المتابعة الدورية للسيدات الحوامل وتأمين الأدوية والفيتامينات والمستلزمات اللازمة وتأمين إحالات آمنة في المشافي. نأمل الاستمرار في دعم الخدمات في ظل العقوبات الاقتصادية المفروضة على سوريا التي تحول دون توفر المواد والمستلزمات اللازمة، إضافة إلى ندرة وارتفاع أسعار التجهيزات والممتلكات الطبية عند توافرها، إضافة إلى ارتفاع الأجور الخدمات الطبية في القطاع الخاص، والتي يتعذر على الأغلبية العظمى من المحتاجين لتلك الخدمات تأمينها. بحب إني هيك خبركم كمان قصة ملهمة، قصة نجاح مرت معي خلال الأزمة بالغوطة. في يوم من الأيام إنه إجت لعندي امرأة حامل إلى مكان عملي برفقة زوجها ووالدتها، وكان وضعها كتير صحي كتير سيء لأنه كان عليها علامات الإرهاق، آلام الشديد بسبب الولادة. كانت قد نقلت بواسطة شاحنة إلى مكان عملي، ولكن للأسف أنه لم نتمكن من نقلها إلى الداخل لأنها كانت في صدد الولادة. ودون تردد يعني صعدت إلى الشاحنة وأحضرت حقيبة الولادة الآمنة، وتمت الولادة بعناية فائقة، وكانت الأم والمولود بصحة وسلامة جيدتين. واستمريت في تقديم الدعم الطبي والنفسي والضروري طبعاً للأم والطفلة خلال فترة ما بعد الولادة وحتى فترة النفاس. وأثناء التأمل في هذه التجربة التي وقعت منذ أكثر من عقد من الزمان في منطقة الغوطة المحاصرة، أتذكر الدور الحيوي الذي تلعبه مهنة القابلة في إحضار الحياة الجديدة إلى العالم حتى في ظروف صعبة. في كل مرة أرى فيها تلك الفتاة الصغيرة أمتلئ بالامتنان للفرصة التي منحت لي للمشاركة في ولادتها كشعلة من النور في أوقات المظلمة. وأخيراً، من خلال مشاركة هذه القصة آمل في تسليط الضوء على أهمية الرعاية الأمومية والتأثير الذي يمكن أن تكون له على الأفراد والمجتمعات، خصوصاً في أوقات الأزمات. إن لحظات مثل هذه التي تؤكد التزامي بتقديم الرعاية متعاطفة وفعالة لجميع الأمهات والرضع. بغض النظر عن التحديات التي قد نواجهها. وشكرا.
Thank you very much, Bushra, for your testimony. Thank you for your work, really, because we always say the real heroes are national and local health workers, Syrian health workers, and we really mean it. All of us who have been in Syria could witness the commitment of health workers to continue to do their job and to save lives, and your job is truly life-saving. What we need and what we should be doing is to try to help you and your colleagues, Syrian colleagues, to enable you to do your job. Unfortunately, we need that external assistance, and we hope by these sort of events to highlight the need to continue supporting health system and health workers in Syria. And you already mentioned what does it mean not to have enough of support, and how that support that you received from UNFPA changed the quality of work that you were able to do. Let's now try to hear what happens if we don't get that support, if there is no enough of funding for UNFPA to provide that sort of support to midwives and other health workers in reproductive health. So let me turn to Ziad Nabulsi, who is the head of Gaziantep office for UNFPA. We already heard from Dr. Shankiti a little bit about northwest of Syria, but tell us more from your perspective, what is funding shortages would mean.
Absolutely. Thank you, Tarek, and thank you. Good afternoon. Thank you, Your Excellency, for convening this important panel and for the opportunity to speak about the critical situation of sexual reproductive health services in Syria specifically. I'll talk about the Northwest. Of course, the evolving circumstances in the region have severely impacted vulnerable groups specifically, and especially women and girls, of course. And to provide some context about the Northwest, out of 5 million people residing in Idlib and northern Aleppo, a staggering 3.4 million are internally displaced. And out of the 2.1, out of the IDPs living in camps and informal sites, who are about 2.1 million, 79% of these are women and girls. More than 2 million women and girls in the region overall require critical services, which include, of course, healthcare, reproductive healthcare services, psychosocial support, education, and of course, protection from gender-based violence. But so the situation is dire. According to the sexual reproductive health working group in Northwest Syria, 41% of the emergency obstetric and newborn care EMONC facilities have ceased operations, leaving about 2 million people, which is 40% of the total population, with limited access to these essential services, including 500,000 women and girls of adolescent age. Now, the dwindling number of operational EMONC facilities pose an imminent threat to the health and well-being of women in Northwest Syria. Without these critical services, women face difficult challenges, including geographic, financial, cultural barriers, leading to dangerous delays in receiving that essential care. This does not only undermine the right to quality healthcare, but also perpetuates preventable suffering and increased maternal and neonatal mortality and morbidity. Now, maybe to talk more about UNFPA and the programs in Northwest Syria, UNFPA remains the sole provider for the interagency health kits to the entire SRH network in Northwest Syria. Unfortunately, these financial funding cuts have severely impacted this crucial aspect. The shortage of interagency reproductive health kits and family planning supplies creates significant barrier to women and girls accessing SRH services. In 2024, we had to reduce our program by 50% compared to 2023, decreasing the health services or the health facilities supported from 11 to 3 only. This reduction left around 470,000 people, including 117,000 women and girls of reproductive age with limited access to EMONC services. What does it mean? It means that more than 1,200 women each month will struggle to find health facilities for safe deliveries, specifically because the facilities near their camps or displacement camps have closed, adding, of course, to the risks to maternal mortality and morbidity. We all know the figures from the humanitarian response plan, but specifically to the Northwest, it's only 26% funded. And this funding recorded in 2024 jeopardizes the provision of the integrated life-sustaining SRH services for women and girls, specifically when the system is already fragile, strained from years of conflict and, of course, the recent earthquake in 2023 further. And this was, of course, added, or the impact was compiled and compounded by these severe funding cuts. I will conclude to say, of course, that the SRH situation in Northwest Syria is dire, critical, and requires urgent attention. More than 130,000 women and girls of reproductive age are expected to give birth in 2024. Without proper care, I'm afraid that preventable maternal deaths will be inevitable. Thank you.
Many thanks, Ziad, for this explanation of the situation in northwest of Syria and of the consequences of the lack of funding and of these critical services that are needed for women and children. But those services have to be provided by health workers, and again, the issue of health workers in Syria has been there since the beginning of the conflict, with many health workers, and we estimate that 50% of healthcare workers have left Syria. Let's turn to Dr. Hani Al-Taleb, who is a founder and CEO of Relief Experts Association, to speak about the issue of healthcare workers. What is the consequence of this migration of health workers from Syria? Unfortunately, this is something we see in other conflicts, and countries in protracted conflict situations often are left with insufficient number of health workers. What does it mean, really, and what is your assessment of the situation, Dr. Al-Taleb?
Well, thank you very much, Tariq. And thank you, Your Excellency, for hosting this event, this much-needed event. And thanks to the esteemed panelists, and deep appreciation, shukran jazilan, to everyone joining us today from Syria and all over the world. Well, as you rightly mentioned, Tariq, while brain drain is a global problem, it can only be seen as a disaster with grave implications on Syria and the world. Nobody knows for sure how many Syrian health workers were lost to this brutal conflict. And estimates from the Syrian Ministry of Health are far from global reports. However, as a medical professional who worked in some of the worst zones in Syria, one thing I'm quite certain of: people stay wherever health workers stay. So if we look at the magnitude of this problem, we find that 949 workers were killed and over 3,300 are detained since 2012. Now, this suggests that they either died in custody or that they require extensive rehabilitation if they were released today. And let me tell you, not a day goes by that I don't remember colleagues that I left in prison, and many more who are no longer among us. On the other hand, Germany, as an example, reported that 6,000 doctors who joined the German health system after leaving Syria, and this number, it goes without recording those who are still under accreditation. At the same time, Turkey reports over 650 doctors employed in migrant health centers in Turkey. Now, much more workers, as I said, are not recorded, with hundreds of refugee dentists and pharmacists unable to work in Turkey, or others pursuing accreditation across the world, and many more who changed their citizenship and are no longer counted as Syrians. All in all, some reports state that Syria lost half of its doctors between 2010 and 2018. Now, this hemorrhage continues. Workers are leaving government areas because of military service or poor economics, while many returnees are being detained. Others are leaving all of Syria to continue their education, secure a better life for the families, get a different passport, or avoid getting killed or worse, detained. In many, many cases, they fall victims to human trafficking while leaving their homeland. And 3 days ago, I did ask workers in Northwest Syria whether they think that leaving is a better option. And 2/3 out of 62 said yes. The rest said maybe, but none said no. And this is alarming. In terms of the impact that this has on Syria, well, Syria is amongst the worst 15 countries on its brain drain index. This reflects the negative consequences of skilled worker migration. The only worst state in the region is Palestine. Northwest Syria has a density of 16 health workers per 10,000 people, which is far less from the minimum international standards in fragile settings, which is 22, and it's far lower than the ratio in government areas, which is 26 workers per 10,000. It takes us as organizations, as health organizations, it takes us up to 3 months to recruit a GP, especially as we go further from the Turkish borders, which are deemed safer, but never safe, safer than other parts of the country. As an example, during COVID, we had to close understaffed clinics when workers were infected or when they joined emergency responses, including the Turkey earthquake. And just to give you another example, a physician in Syria sees 30 patients per day. Now, 1,000 lost doctors, killed doctors, would have served a population of 2 million. That is almost half of Northwest Syria, or as if the entire population of Vienna or Gaza woke up one day without any doctors. Now, so it's not all grim. We've come up with multiple solutions to overcome this problem, and I'm glad that I've seen some questions in the chat touching base on this. So I'll tell you about some of what we have done basically to overcome this. The picture is not all grim. As I said, many workers, heroes actually, like Bashira and others joining us from Syria today, they remained in Syria, and we are challenged to support and keep them. 2 universities trained 500 physicians in Northwest Syria, half of them are female, and another university started to do so in Northeast. But these graduates lack clinical experience and recognized accreditation. So we came up with many solutions, but I'd like to tell you about 3 brilliant and pragmatic solutions that were introduced in Northwest Syria. We have enough evidence that they work and should be expanded, but we can never do that without the support of donors and other stakeholders. The first is the primary healthcare networks introduced by WHO, which used to be funded by ECHO and the British government. It provided an excellent transitional solution to deliver education and staff supervision in the absence of a fully functioning system. I was privileged personally to take part in this project, which supervised 1,000 workers in 60 facilities using a system to first test and then train workers. What is really fascinating about this is that it replaced vertical programs where staff could only be trained in a particular area, and then you'll need more resources to train them again in other areas. It replaced all of that with a comprehensive approach, where staff received continuous education and supervision for 3 years to ensure that they apply what they learned, identify barriers to applying their knowledge through regular inspections, and then provide health facilities with material support and tailored recommendation for them to overcome these barriers, which at the end of the day only serves to improve the quality of services and save much more lives. What I also like about this project is that it's an excellent example of localization, with a committee of 11 Syrian NGOs overseeing this project. And because of this, it received an unprecedented local support to a point where more health facilities started to measure their performance according to the standards set by these networks. The second remarkable example is the midwifery schools supported by UNFPA, which trained up until today, it trained 140 female workers and traditional birth attendants into becoming certified and supported midwives. Now, this expanded their ability to serve complicated cases, and it allowed them to save many more lives despite the dire shortage of reproductive health specialists, as was mentioned by Muriel and my colleague Ziad. The last remarkable and really remarkable solution initiative that was introduced in Northwest Syria is the Syrian Board of Medical Specialties, which was and is funded by Germany and recently the EU. This body trained over 300 resident specialists across Northwest Syria through a wealth of expertise from domestic and diaspora health professionals, with an ambitious plan to support more specialists and GPs in the public sector. Now, lastly, I just want to say that it takes a significant amount of courage for a health worker to show up to work every day in Syria. Our only option is to make sure that we are not leaving them behind, that we are providing them with the adequate support that they need to allow them to breathe in a sense of stability into the beaten down communities in Syria. And thank you, and over to you, Tarek.
Thank you very much, Dr. Hani, for this powerful advocacy for health workers. And I think we all agree on how much it is important. You said people stay where health workers stay. I think that's something I will be using in the future, because it is absolutely true. If there is no health, then there will be no peace, and people will leave the place if they can't access health services. I see lots of questions coming to chat, and that's really good to have this level of engagement. We will come back to some of them, but let's first turn to Ms. Rosa Crestani, who is the head of WHO Field Presence at Gaziantep, to tell us more about a particular situation of this area when it comes to funding shortages, what's the health situation, and what risks we are talking about if we don't get funding we need. Rosa, the floor is yours.
Thank you, Tariq, and thank you for all the presence and the encouraging chat questions. Talking about Northwest Syria and giving an example on an impact on funding cuts, let me start by giving you the ground reality here. As already said, in Northwest Syria, we are talking in this region, we are talking about 5 million people, and we are talking about 2 million living camps since years, and some of them moving from camps to camps. So you can imagine like towns and villages as IDP camps. And such a situation for sure presents itself as a breeding ground for illness and infectious diseases. The reality is that out of 10 people, 8 in Northwest Syria require full health assistance and don't have any capacity to do it on their own or privately. And after 13 years of crisis, we are talking about 1 on 5 people also suffering from mental health disorder, depression, suicide thinking, everything. The health system has been completely disrupted, and it's very difficult to maintain a kind of normality. Already we are talking about a third of health facilities that they are non-functional since the beginning of the crisis. We are talking about escalation of conflicts and natural disaster. The earthquake was a crisis on top of another crisis. And we didn't have enough time with all this emergency to focus solely on building the resilience of the health system. That We are only been able to start since a bit. So the functionality of the health system is entirely dependent on donor support. This is the situation. And the impact of decreasing funds right now is really heavy. Health partners are adapting to the situation by prioritizing exercise. So it means presents as an opportunity to become more cost efficient because the funds are decreasing, and to try to find as much as we can more sustainable solution. The problem is that this is come with a significant human cost. For example, from a woman from northern Aleppo, she told me, I endured the most difficult journey of my life when I came to give birth at Abu Madi Hospital to find it closed 2 months ago. I fear for my life and for my child's life, and I have to travel 17 kilometers far in a difficult situation in search of another hospital, another maternity. I almost gave birth in the car and lose my life and my child's life. So this is an hospital closed that is supposed to serve 100,000 people in the surrounding. Another story and the situation, what is the impact? At the Idlib Oncology Center, one of the few centers available for basic cancer, Manther, a man that suffers from renal cancer, says that after 6 months of chemotherapy, I was told medicine are not anymore available to continue my treatment. I'm unable to work to buy medicine, especially since due to the displacement, we have left our home and don't have a steady income. And I know that stopping treatment will deteriorate my condition, but I'm helpless. There is nothing I can do, like many other patients. So today we know that we are finding ourselves having to prioritize the most vulnerable among the vulnerable. So we are in need to choose. And in simple terms, we are at a situation where we must decide who lives and who dies. The current projection in funding, if it is confirmed, by the end of 2024 will give us nearly half of all functional facilities in Northwest Syria with fully or partially cease operation, mean closing down. So this means that 1.5 million people will lose access to health. 1 on 2 children will be at increased risk of infection disease and outbreaks. 500,000 women will lose their access for obstetric care, and further loss in access to mental health services. So that is clear. And from my side, I want to be, I may be short, it's a lot was already said, and I think that we express enough ourselves. It's really clear that the right to health for all in Syria is become far from reality. And we need really to ask ourselves, are we going to leave the most vulnerable behind? Yeah. Tarek, up to you.
Thank you very much, Rosa. And you said it, and we heard it before, that we have to make difficult choices. Health workers need to make difficult choices on how to best use available resources. And we will all agree that health workers dealing with patients, but also public health professionals, should never face that choice, should never be in a position to decide who will die and who will live just because of the lack of resources. And I think that's one of the key messages here. We received lots of questions in the chat, and I thank you for that. So let's try to, we have some 30 minutes. I have some other questions that we have prepared, but maybe it is better that we try to move to questions we have received online, and some of those you have seen in the chat. So let's start with David Carden, who is a Deputy Resident Humanitarian Coordinator for the Syria crisis. Very straightforward question from David. For UNFPA and WHO, how much funding is actually needed for your agencies to carry out your critical work to support the provision of health services, including reproductive health, as well as safe spaces for women and girls. We may mention the amounts of money, but why not repeat it again? Because I think this is why we are here for. So I don't know if this wants to be first Muriel and then Iman to really tell us about what is needed.
Yes. So for UNFPA, for whole of Syria, we have a modest ask of 67 million. And I say modest because the needs are bigger than what we are asking for. So it's 67 million. But what is important to note is that only 41% is currently funded, which means without mobilizing the remaining amount that is needed, we will have to cut back on a number of these critical services that are being provided. So the short answer is we are only at 41% of what we need for this year.
Iman, would you like to add from WHO side? We may have lost Iman for a second. I can't see her. So we'll come back to Iman later. Let's go to the questions that we have also received online. We have Isatu Sar with a number of questions, but there is really one that comes to mind to all of us. I think, what factors have contributed to the decline in funding for humanitarian health services in Syria? And what are the long-term strategies that are needed to build resilience in order to improve healthcare outcomes? I don't know who wants to start this. I mean, we see this in many conflicts that after years of a crisis continuing, the funding is decreasing. But I don't know who would like to say something. Maybe Muriel, you can ask. You can start, and maybe then Your Excellency, Mr. Kreuz can add something on how we see this donor base. And please, anyone who wants to add, just raise your hand so I don't have to make a call.
Okay. I think, the factors would be hazard guessing if we want to go into what are the factors behind the decline. What we do know is that it's been 13 years of the Syria crisis. What we also know is that there are emerging and intensifying crises across the globe. So our message to the donor community, our message to the international community is that Syria crisis should not be forgotten. That is the first message that we are communicating. The second message is looking at the opportunities that we have through smart investments. As I said earlier, we know when we invest in robust primary healthcare, when we invest in preventive services, when we invest in surveillance, in data, which can help us to focus our limited resources in the areas that are most in need, when we invest in data which tells us who are the most vulnerable, and we saturate and bring services to those communities, we know that the impact will be meaningful, the impact will be there. So that is the message we are communicating. We shouldn't forget Syria crisis. And two, we know as the development community, as the humanitarian community, we have solutions collectively which we can harness in order to maximize the limited resources that we have. And then the last message is that business as usual cannot be the modus operandi. What do I mean? We cannot continue putting out fires, dealing with the immediate emergencies that we see. We need to progressively invest in early recovery, invest in putting people at the center of our programs so that they own the programs and we build their resilience. That's what is going to be the game changer going forward. So really, that is one of the messages to the humanitarian community as well as to the donor community.
Thank you very much. And indeed, we often talk from the UN side about different conflicts, and it may look and some sort of competition between emergencies, but it should not be that, and it's not that. What we are really trying to do is to say that people's lives are important everywhere. I see the hand from Rosa. Maybe you wanna speak about the second part of the question on building the long-term resilience, unless Your Excellency Peter, you would like to add something on this issue of decline in funding. Yes, Your Excellency Peter, why don't you start, and then we will go to Rosa.
Yeah. Thank you very much. Thank you very much. I mean, from my point of view, I think it's also necessary to remind ourselves, while the support of WHO and UNFPA is extremely important, but it is a very, very big ask, and actually very unfair to expect of these organizations to shoulder the responsibility of a healthcare system for a whole country. Can't work like that. We need to have all this network that there used to be of companies that produce medical drugs. Syria used to have a very, very powerful pharmaceutical industry, used to export to some 50 countries. There used to be no problem to import the necessary spare parts. And unfortunately, still, although it has been discussed for a decade, no solutions were found to address the overcompliance to restrictive measures. And this is something that really hurts also the credibility of those who decided on these measures. And I say this also with a self-critical undertone, because if we find out that there is a problem, we should address this problem. And the second issue is the health system of a country should be put on a more sustainable basis. And here many other questions also linked to the economic base, to the income of people, to the sustainability at the local, regional and national level. I mean, lots of issues come here to mind. And I think it's not how should I say, very future oriented to just hope that every year donors will come up with the necessary funds. It's necessary to look for more long-term solutions. Early recovery was mentioned, resilience was mentioned. I think what would also be helpful, and there are first projects where I see a good start actually at the local level, to take the population, to take the citizens into the picture, to discuss with them, to discuss priorities, to have an inclusive approach at the local level. And there are actually initiatives that start in that area, also in the health sector. I know that there is a very interesting initiative in the countryside of the province of Sueda, for instance, by Syriana. And the question is, how can we work more in this direction to build sustainability and to get out of this logic that the situation actually gets worse every year and we have more needs to cover every year. And here, overcompliance is an issue. We know that the restrictions were never meant to harm health, but the truth is, through overcompliance, they do. And this is something that really needs to be looked into, and also how we can strengthen the resilience of the health system in the country and the sustainability of the services provided. Thank you very much.
Thank you very much, Your Excellency. And I think you touched on a crucial point, and that's that international agencies cannot replace the health system as a whole. And the only solution is that health system in any given country becomes sustainable and self-sufficient, including pharmaceutical production. We have back WHO representative Dr. Shankiti. Iman, the question was about actual amount of money needed to continue to provide the services that WHO and UNFPA have been providing. We heard from Muriel. Would you like to say something on that from WHO side? And then we will go to Rosa on the question of building resilient health system.
Thank you, Tarek, and I'm sorry for the internet here. I mean, in response to your question, under the humanitarian response plan, WHO has indicated the need for around 168 million, out of which around 20% have been received and 10% is in the pipeline. So the gap is around 70%. And we are seeing this year a 30% decline in addition to another 30% from last year. It's important to note that the entire health sector, because we are also the leading agency for health, have requested around 291 million. And that is really important to avert the closure of facilities and losing the access for healthcare and for treatment. I wanted to answer the question on resilience, if I may, Tarek, because I will be very, very brief, if I may. In addition to what His Excellency said and what Muriel said, we need to bring the services closer to the people. We need to engage with the civil society, with the communities. There's a question on the NGOs and how we can support them more. Is that working closer to the community, bringing the services closer to the community is going to be key. Additionally, looking at the components of the facilities, healthcare workers, supply chain, all of these are important components. If supported, the health system itself could retain at least the level of services that are being provided at primary healthcare level, and also could work on a package of care that could be expanded into scale. What is also important is ensuring that we're protecting the public health domain and the ability to respond, to detect, respond, and mitigate any pandemics or epidemics or outbreaks. And last but not least, and it's something that Muriel touched upon, all our decisions needs to be made based on evidence, based on data collected, and that is going to be key for the future. Thank you, Tarek.
Thank you very much, Dr. Shankiti. Rosa, sorry for keeping you waiting.
Yes, because it's quite a lot was already said about which kind of solution. We know that the funds are decreasing and it will not stop for the next year. I think also beside what Dr. Iman and everybody's already said, I would like to add also the component of the governance in the system. You know, we need to work also together, not only with the NGO, with the health partner, with the other agency, etc., but also with donors, and trying to work together toward a parallel capacity. In one side, we need to ensure that crises, outbreaks, natural disaster, floods, even last week and this week already, another announced bad floods and bad weather that will give problem of the 2 million living in camps here. So we need to maintain this capacity to intervene for respond to the emergency, but in the same times, we need this type of support that can support us on the governance, on the fairness, for example, for salary for health workers, on the education, on the coordination on the system, on the guidelines. And this will, at the same time, build back the system and build back a coordination that will strengthen and sustain in future years the system, even for the response, because the response of emergency is still important. So we are not asking, okay, money like this or funds for everything. We are really engaged on a possible discussion and engagement on a solution for sustainability with a double way, double pillars, emergency response and resilience. And this will decrease also the weight of the needs if we manage to coordinate better, govern, and giving more support and localized support. Thank you.
Thank you, Rosa. I see Dr. Hani has his hands up. Dr. Al-Taleb.
Yeah, thank you, Tarek. Excellent points picked up already by our panelists and His Excellency. I'd just like to touch base on the idea of resilience. I think that's an excellent point, but how can we talk about resilience and building a better future if we cannot even protect the staff that work for us every day, that show up to work every day, and they put trust in us every day to come up and do their job while we're basically unable to protect them. But that's a big issue, right? So what the least we can do is that make sure that they are sustained, that they are provided with support. I've seen questions talking about how can we retain and support these staff. There are many ways. And I think that the NGO community in Syria has already been so creative in coming up with multiple solutions on how to engage and how to support and sustain these workers. These workers, they have their intrinsic motivations to stay in Syria. They love the country. They want to help their people. They are patriots in many ways. But a patriot on an empty stomach for 10, 13 years is a quite difficult combination. So we have to be sure that we are really, really investing in providing long-term support. And the reason I'm saying that NGOs have been creative in coming up with solutions to overcome challenges is that as an NGO person, as an NGO worker myself, we found ourselves always faced with the problem that we have 3 months project, 6 months project, 2 months projects, but never the ability and the capacity to plan and actually implement solutions long-term, which is much more cost-effective. Instead of renting so many cars, you can plan ahead, you can put that money in a better use, and you can reduce the cost significantly. We can do the same. We've already been doing the same now with training program, with education program. Instead of doing haphazard trainings here and there, putting money here and there, and that's it. We're now moving towards longer term solutions where we are providing systematic training programs, which are not only helping our service delivery, but also empowering these workers. They feel much more empowered when they receive a better education, when they have a pathway for them to continue their education and look after their families. And I think again, the NGO community has already accumulated a wealth of expertise. We cannot dare to say that, well, the NGOs are only needed in the emergency phase, but then, we no longer need them. Look at many countries in the world, and you can see the health sector actually run by non-profit organizations who were working closely with local authorities, with local actors, but working more in harmony, but never replaced, because they already came up to a point where they were becoming cost-effective, able to manage services, have already accumulated this expertise. So one of the really important messages that I'm giving away here today is that investment in the NGO community, especially local NGOs, is a must for now and for the early recovery phase, and hopefully for the better future. Over.
Indeed, it's a very important point on the role of NGOs in the emergency phase and early recovery before the health system as a whole can really take over and provide services. So thanks for that. I see hands coming up, so let's just keep talking. First, Muriel, you had your hand up. Please go ahead.
I just want to come back on the issue of funding. While we have shared the funding gaps, etc., I think one point that we missed out is the importance of flexible funding. And this ties very closely with Dr. Iman's point, where she was talking about being evidence informed, because if we bring together the two, the flexibility in terms of the funding that we get, matching that with following the evidence, where are the vulnerable people, that will really help us to have a great impact when it comes to maximizing the limited resources that we have. So that's one point. The second point, I think, is also about international humanitarian law. Coming from UNFPA, I can tell you right now we have a service point in Deir ez-Zor, somewhere there, which has been closed for the last 3 weeks. We cannot deliver services because it is not safe for our staff to do so. It's not the first time we've had disruptions of services in some health centers, in women and girls safe spaces, etc. So I think another message coming out of this dialogue is that for all of us as humanitarians, we have to ensure that we adhere and we articulate the importance of international humanitarian law so that services for vulnerable communities are not disrupted and humanitarian workers are safe, they feel safe to deliver the services as well.
Thank you. Thank you very much. Let's go first to Iman and then to Ziad. Iman. Dr. Shankiti, you have the floor.
I'm sorry. I wanted to touch on the decline in funding question, if I may. And it's not only WHO or UNFPA, but it's the whole it's the whole UN country team, whether it's UNHCR, whether it's WFP, whether it's UNICEF. Everyone is facing the same situation. So there's a global decline in humanitarian funding, and that could be also translated into the fact that we have a lot of competing emergencies going on in the region and outside the region. And of course, I mean, the protracted nature of the security of Syria emergency, that it has been going on for 14 years. So I think there's more and more acceptance now to look at Syria in a different lens and to see how can we look at early recovery, but an early recovery from a humanitarian perspective, from an emergency perspective. I think that's going to be key. And the last thing that I wanted to say, and I wanted to touch base on what Muriel said, is the international humanitarian law. So in the beginning, I did mention that we had to suspend our referral services in Al-Khol camp, but what I didn't say is that the camp management decided that WHO presence in the camp altogether is not requested, and they revoked our access permits to the camp. That means the camp will not have access to surveillance or CCE, too many water quality monitoring, too many activities that we conduct inside these camps. Now, it's important to note that many member states now are advocating on behalf of WHO to revoke this decision, but this is a pure IHL case where you are, I mean, the camp management is preventing the inhabitants of the camp from accessing other services, excluding the referral service. So I agree with Muriel. A lot of IHL concerns need to be taken into consideration when we are discussing access to services in Syria. Thank you.
Thank you so much, Ziad. You had something to add as well.
I just wanted to answer the question that was posted on the chat directed to me, if I may.
Sure, please go ahead.
So the question was about the impact of the earthquake on the provision of sexual and reproductive health in northwest Syria, and what measures can we currently undertake to address the current situation. I think the health workers in northwest Syria have been operating under extremely challenging conditions since the earthquake. The destruction and the severe damage of about 55 health facilities forced healthcare providers to work out of temporary structures and tents and containers that we actually provided and assisted with. I was in a mission 2 weeks after the earthquake, and we have seen deliveries in tents just outside the destroyed health facilities. The health staff themselves, health workers, have suffered also from the earthquake, as a lot of them have lost families, they lost homes, they lost friends and loved ones. Despite these difficulties, they also persisted in delivering essential care with very limited resources and support. We have seen that, across the earthquake-affected areas in Syria. Women and girls seeking maternal health care services faced also a lot of obstacles. As I talked about already, the fragile healthcare infrastructure was already there, specifically in Northwest, creating a critical situation for maternal health. They had a lack of access to safe delivery facilities and crucial services like prenatal, postnatal care. And of course, the risk of complications during childbirth has risen due to the poor sanitary conditions and lack of medical supplies. What we witnessed as well, and I came actually on the mission 1 year after the earthquake, which they're still using the supplies we provided back then during the earthquake response. And this is, of course, a complication, or when you have say a limited amount of funding, then the healthcare workers also tend to prioritize their usage of medical supplies, which is also an issue. So the lack of funding this year also has made it challenging not only to continue, but also to recover from the earthquake, that we are still seeing a lot of people, but also healthcare workers, facilities are still struggling to continue and provide services and recover fully from this earthquake. And I think, if we can think about the Northwest Syria specifically, and I echo what was said earlier, that before the need for a sustainable long-term funding that focuses on early recovery is essential as well to avoid and absorb, to absorb any kind of shocks that may happen in addition to or in the future. And this is how we really mitigate those risks. Over. Thank you.
Thank you very much. I'm aware of time, but and there are a number of questions that you can all see in the chat. Maybe you can bilaterally reply to those who have asked. Some of those have been answered, but maybe I would just really, as a last point, to hear whoever can say something. We didn't mention much mental health, and there was a question in the chat. There is a lack of resource. There's a lack of trained health workforce. There is a lack of mental health centers. What is the situation? What needs to be done? I don't know if who would like to say something about the mental health, and then we will try to wrap up.
Tarek, I can start if I may. And I think one of the major things that we can do is the integration of mental health in primary health care. And it's important to note currently there's a lot of efforts that service is being provided at PHC level. It is also important to note that there's not too many specialists in this area that could be deployed at PHC level. So that might be one hindrance. The other one is the availability of medications and the healthcare worker that could dispense these medications. But there's a lot of efforts, and I know that I'm asking my team here, and do you know the percentage?
Of integration at PHCs, it's around half.
50%. So around 50% of the primary healthcare centers are providing this service at PHC level. And that is the first level where you have prevention. And then, of course, if there's a need for referral, then they are referred to the nearest hospital. So integration is one. The second one is to adopt a multi-sectoral approach, and specifically working together with the education sector. This could also allow us to have more and more of these specialized expert healthcare workers that could deal with the increased needs in the community for mental health services. Over to you, Tarek.
Thank you. And maybe Dr. Al-Taleb, do you want to say something? Because it's really also a question of available health workforce.
Just to complement what Iman mentioned, and maybe you can allow me an opportunity to close with a closing remark later. But to complement what Dr. Iman mentioned, I think the PHC networks that I mentioned earlier provided a really great opportunity for integrating many services at the primary healthcare level. WHO in Northwest has been doing a lot of work to integrate several aspects, including mental health, in primary healthcare, and we have seen that this was very much welcomed by workers in Northwest Syria. So I think that this is one of the areas that should be supported and enhanced in the future. So over to you, and then maybe with closing remarks later on.
Thank you very much. We are already running out of time, so I'll try to. I was taking a lot of notes, and I'm going to quote you whenever I can on a number of things you have said. But I think what we can all agree is that if we don't collectively, as a health sector, that means WHO, UNFPA, but also all the other partners working in health area, the consequences will be serious, not only at a health level, but also at a societal level. Lack of medical supplies and equipment, limited access to healthcare services, closure of health facilities, limited access to sexual and reproductive health services, including family planning and safe childbirth. And then that leads to increased risk of communicable diseases in non-access for treatment for non-communicable diseases, diabetes, cancer have been mentioned, and decrease in mental health and psychosocial support. So all these elements that normally a health system is providing would be at risk. So unfortunately, if health, it always goes in a wider circle. If there is no funding, then health service can't really provide a range of services, and then those difficult choices have to be made, and we don't want and there. And I think what Muriel said is we know what needs to be done. We just and I think health workers in Syria, like Bushra, know what needs to be done, and they are ready to do it if we provide all the support we can provide them, so they can do their job. And as Sani was saying, we hope that health workers in Syria will stay. They will feel safe, and they will feel appreciated, and they will feel they do something that is respected by everyone, including authorities, including community, including us from international organization. So the recording of this session will be posted on the social media of WHO in the region and country level, so it can be accessed. And I hope that people who are watching us have noted the expertise that we had today, and they can reach out to any of the participants today with further questions and with further engagement in any possible way. With this, I would like really to give the floor back to His Excellency Peter Kreuz to give really the final word, and we again thank Embassy of Austria, Government of Austria, UNFPA and WHO for organizing this event. Your Excellency, the floor is yours for the closing remarks.
First of all, really, let me thank all participants. Actually, a lot of very important points have been raised. Also, more focus on the staff that keeps the services going. I fully subscribe to that. We need to take care of them. We need to see that they have the conditions that they can keep up their good work. They need more support, and they need also to feel that they are not left alone. Yeah, this is very important, and that we aim for more sustainability, that we aim for more resilience, and it's connected to the economic base of a country, because without an economic base, it is very difficult to have a health system that really works. So everything is linked, and this leads me really to the notice that we have observed, especially in the connection to the Syrian conflict, that everything became incredibly political, even the humanitarian, even health, everything. And I think if we take looking at things politically to the level we should take it, we should say looking politically at the situation means to have as a guiding line looking at what the vast majority of the population needs. This is the real political look that we should adopt. We should not say political and mean something totally different. Politics should be about the people in a country. And when we have this as our guiding line, and I know that WFO, UNFPA, and all those who spoke today have this approach. But I also see in international discussions, this is not always the approach chosen. So we should advocate to really look at the needs of the vast majority of the population. And that is an approach that will a better future, I'm very sure. Thank you very much for inviting me to co-host this event together with WHO and UNFPA. Thank you.
Thank you very much, Your Excellency. Thanks to your government for everything it's doing for people of Syria. Many thanks to all panelists for sharing their expertise and for their work. And thanks to all those who have been listening to us today for sending questions. As Ambassador has said, we all need to continue the advocacy. We all need to highlight the need of Syrian people, and we hope that the future will be brighter for Syrians wherever they are. With this, I wish you a wonderful day and hope to see you again in one of the future events.
Thank you, Tarek. Thank you, panel members. Really appreciate it. Thank you all for those who attended.
Thank you.
Thank you.
Thank you, dear.
Thank you.
Shukran.
Shukran.
Bye, dear. Bye, Maureen.
Bye-bye.
Bye-bye.
Thank you.
Thank you. Bye-bye.
مع السلامة.